Good afternoon, everyone. This is Raquel from the COE here. I am joined by Dr. Amina, Alio, and Pam. So thank you for joining us for the third webinar on systems building. This one in particular will be focused on the partner survey that was completed last year on behalf of the MITCH programs. And just a couple of things to preface the webinar. The results of the partner survey was shared in a report and also via a call with the MITCH programs. And so in today's webinar, we've also invited the McV programs as they were listed as partners or collaborators in your partner survey. And so we want to bring them into the conversation that we're having today in terms of how do you use your partner survey results for strengthening your collaborative, because what we want the MITCH programs to do is to, if they're not currently partnering with their local McV program, we want you to start or strengthen that relationship. And so Dr. Alio will give us, will present on how could you use those results to identify steps towards improving your collaborative overall, and also start building your partnership with your local McV program if you have not already. So the webinar will be recorded and shared on the website as well, if that's something you want to listen to at a future point, and also have conversations with your team. And so if you feel free to raise your hand along the way or send us a message through the chat box along the way, that we can maybe pause and make some clarity or make some give you some responses. Thank you so much, and I'm handing it over to Dr. Amina Leo. Thank you.
Good afternoon, everyone. Welcome again to the third part of a series on systems building. As you know, working alone is sometimes a lot easier, makes us go fast. But when we talk about systems building, we know that we have to do it together. And this is an African proverb that says, if you want to go fast, you go alone. But if you want to go far, you go together. So the idea is that systems working together as a community or a collaborative can be very challenging. It takes patience. Some want to go faster than others. Some want to go one direction or the other. But the key is if we can get together and move along the race together, we can actually get quite far. So today we're focusing on strategies for actually working together, specifics on how to engage our partners and what we need to do to make sure that we are moving along the continuum together as a community. So we're going to review the partner survey results very briefly. And then talk about some strategies for moving from one partnership to the other. And I'd like to hear from your experiences, primarily the MITCH programs, on what they've done with the partner survey results, any challenges they found, any planning that they've done as a result, etc. And then we'll end by talking about key elements of a successful collaboration. So if you recall, the partner survey objective was to look at partnerships and look at the strength of the agencies that the MITCH programs are partnering with. And we did this with all 23 MITCH programs who identified their local partners. So we didn't survey all of the partners. However, we did survey a select group, around 40, so no more than 40 partners was a target. So the goal was to measure the strength, but also to look at areas of partnerships where we need strengthening, where there needs to be higher levels of trust. We need to get agencies more involved, etc. And then looking at service areas that are lacking partners. With the population that we're serving, we want to make sure that we're addressing the social determinants of health, which means it's not just maternal infant health agencies, but also agencies from non-health related sectors, such as housing, for example, or the justice system or other entities. So the survey was to allow the programs to be able to identify who's missing and start the conversation about who do we get to the table. It also allowed us to establish a baseline. So if we were to look at these partnerships again in a couple of years, we would know how much improvement there has been. And really the primary goal is to inform planning, to help you plan for future collaborations and planning for ways to improve your partnerships, your network, so that we can serve the needs of women and children in the community. So overall, what we did is look at all of the 23 Mitch programs, and we took the value of the value score, which was on a scale of 1 through 4. And if you recall from your report, the overall value was looking at power, influence, level of involvement, the number of resources that the agency provides, and as well as trust. So based on that overall score, we placed each Mitch program in one of the levels of collaboration. So if we look at collaboration as a continuum, we start out isolated. Everyone's doing their own thing. Everyone has their own objectives and the services that they provide. And then you have communication, where we start to talk to each other, start networking, start sharing information. Then hopefully that leads to coordination. So setting up ways or avenues for agencies to work together on a case-by-case basis. For example, working on sending referrals or receiving referrals with a particular agency. And then from there you want to move to collaboration, which would be where you start to think about working together a little more in depth, perhaps project by project basis, looking at planning for addressing the needs of the population together, or looking at some issues that perhaps you want to work on together. And then coordinated community response here is really full-on collaboration. You almost depend on each other. You work together, you share a significant amount of resources, and there's a very high level of trust at this level. So if you think about meeting, those of you who have official times or names of your collaboratives, you will probably be in the collaborations level or stage. So everyone is different level, but you can see that the Mitch programs were usually in the coordination or collaboration stage. So only 3 were really in the coordination stage, meaning they probably have not yet organized official meetings with their partners. They probably meet with partners separately, or meet with a few partners officially, but not with everyone. And collaboration, you probably set up some form of formal meeting or MOUs or other types of trying to make it a little more collaborative and a little more official or formal. So everyone is kind of really doing well, moving along the continuum, but of course there's always room for improvement. And even if we were to get to the coordinated community response, where we really get together and work to address the issues of the maternal infant health issues in the community, there's still the issue of sustaining collaboration. So that takes a lot of work, of course, especially in agencies where staff come and go. So there needs to be almost a rebuilding of trust with the individual. However, at least at this level, the agency itself is involved. So that makes a big difference, and it helps with staff turnover. But sustaining the collaboration is important, and of course, we're always looking to increase the number of partners, not just in numbers, but as far as the needs that are needed, the needs that need to be addressed for the community. So as you're sustaining the collaboration, you want to also think about additional partners to involve. So at this level, I believe that Kristen talked about this, bringing in people who can actually make a difference as far as policy is concerned. So this would be the level where the collaborative is ready, has an objective, has a policy that they want to address. They have the data, they have their coordinated efforts to address, to propose this policy, but they would need someone that has the clout to be able to make this happen. So might want to consider bringing in somebody from the policy world or the political world at this point. Whereas if you invited someone from the political world from the beginning, you're still in the phases of organizing and they may drop out, thinking that you're not really there yet. So the point is that when you're sustaining, when you're coordinating community response, you still have to invite new people. So you're back to getting to people who are isolated, communicating with them, networking, inviting them, and making sure that they understand the objectives and that they have buy-in. So again, this is just an example of a continuum. And really, if you think about isolation being at the individual level, and then it moves on to communication, which is more service level, agency level, and then it goes in depth. So the way we look at this, if you go to the next slide. So the more involvement there is, the higher the trust, the more open the discussion, the more reliability, the more influence each partner feels that they have, the more support they have of the mission. All of this really helps move the collaborative along the continuum. So in the results that we found, there's a high level of trust among most of actually I think all of the collaboratives of the MITCH programs. But there might be other areas of improvement, such as being more in support of the mission. Some agencies don't really understand their role in improving maternal infant health, etc. So if you look at the different levels, the isolation to communication is really on a one-on-one basis. So you identify who's not at the table. And if you are one of the agencies and you feel isolated, then you also should make the effort to communicate and find out what's going on in the community. But in the realm of collaborative, identifying isolated agencies, networking, reaching out to those agencies, communicating with them, sharing information, whether it's newsletters or sharing information about your services available that their clients may benefit from. So again, this is really on a one-on-one basis. So for communication, as I was saying, it's a little more coordinated effort because here you're building the partnership. So you have many partners. You want to slightly formalize the communication, information sharing methods. Whether you have meetings, do you have a listserv where you can send an email out to everyone at the same time? Do you have websites where you can post things and share with your partners, etc.? So whatever communication form that you want, here you would start to think about it and make sure that you implement it. So this is more on a case-by-case basis, as I mentioned earlier, and referrals will be an example of a resource that's available and that you would want to share, or that others would want to share with you. So moving from coordination to collaboration. So if you were at this level, and it looks like there are three MITCH programs that are here. If you wanted to strengthen your network, you would start to make sure that you have formalized your meetings and your communication, of course, and start working together on a common goal. To do that, you want to make sure that everybody understands their role and they understand that their contribution is important for maternal infant health, and that, again, you can continue with the resource sharing. So here, if you're starting to formalize it, you can start thinking about developing, having MOUs or letters of agreement at the agency level. Because as we've discussed many times, if you base a partnership on one staff member, then you risk losing that partner in the future, because the staff person can leave and the next person may not know you, and that way, and then you have to start over. So if you have an MOU or a letter of agreement or some form of formal agreement with an agency, that opens the door for the next staff person, if there's turnover, to actually know that there's something formal going on and that the relationship has already been established. So the goal here is strengthening the network, and everyone is different. There are some that are really good at sharing resources, some networks, and others still are working on trying to set up official meeting times. So these are not boxes, really. These are just kind of stages of a continuum. So you may be doing something at a really higher level, and then other things that are more at the lower level that you need to move along the continuum. So these are just general boxes, not very firm. So to moving from collaboration to coordinated community response, again, here you've strengthened your collaboration, but now you're really trying to work around a common mission, which for MITCH programs would be to improve the health of mothers and infants. So to really work together, share significant amounts of resources, and very importantly, everybody should be clear about their goals and their role. And you can't get here without high levels of trust. So if most of the programs, the MITCH programs already have the high levels of trust, then at least you have the basis for carrying on and making this work. And here, it's really at the community level that you get everyone working together towards one goal to improve the health of the community. So as I was saying earlier, again, sustaining collaboration. This shows you that really building collaboratives is a continuous process. You don't get to one level and sit back and relax. Sustaining it is as much work as building it. Maintaining communication, especially with staff turnover, maintaining clarity, sharing roles, responsibilities, and sharing data. So you could have a data sharing agreement with a particular agency in order to monitor progress or do a needs assessment for your population that you're serving. But here's really community level response. Again, continuous assessment of the progress. How are we doing as a collaborative? Have we met our goal? Do we need to, if we address housing, created a policy, who do we need to have at the table to make sure that this policy is implemented in our community, et cetera, et cetera. So again, identifying who's missing and bringing them to the table. So, so I wanted to hear a little bit about what some of you have done with the partner survey results. So I know that I've spoken with a few of you that call for technical assistance about potential areas of improvement and what you could do, what you could share with your partners, etc. So I asked a couple of programs to be ready, but as they're speaking, I would love to hear from other programs about how you use the partner tool results, the partner survey results. How did you share it with your partners? How did you do it? How did it help you with planning? Have you made decisions about next steps that you want to make, areas that you want to address for your partnership, and any lessons you've learned, etc. So, Mandy, are you on? So Mandy from Orange County, I gave her the heads up to, I think so. And Mandy, I forgot your last name, so we're trying to find you on it. Is it Stuart? Mandy? All right, thanks. We gotcha. So again, I gave Mandy the heads up and that I would call on her. So thank you for agreeing. So I'm sure on your PowerPoints, if the slides that you received, you saw that Sharita was on for Rochester, but unfortunately she had another meeting, so she couldn't be here. So Mandy, you're on.
Okay.
You want to tell us about how you use the partner tool, the partner survey results?
Well, we actually haven't done a significant amount with it yet. We reviewed it amongst ourselves, and then we had an in-depth discussion with our partners at the state on, making sure that we understood where we need to work on things and things we need to improve on. We got the results just before we had our advisory board meeting. We have an advisory board meeting every quarter with our partners. So we did tell them that we got the results back and who was involved. And then we said that at our next advisory board meeting, we'd be sitting down with them and sharing, some of it so that it will help us focus where we're going forward from here. We do have a lot of collaboration between our partners. A lot of them are on our advisory board, so we meet with them. We share our data with them, and they share with us so that we can kind of put our focus on where we need to go next, with that next quarter. So we do have a lot of collaboration that way. We do some activities with some of our partners. We try to involve our partners to have trainings for the community or trainings for other agencies, trying to bring us all together. And we are in the process of doing some MOUs with, our partners like Planned Parenthood and some of the shelters that we have in our county. So, we do work with them a lot. We do work with companies. We have purchased breastfeeding pumps, hospital grade pumps, and we go to agencies or companies that have a lot of women who work for them, and we look at their breastfeeding policy, and we make some changes to that if we need to, and we supply them with the breast pump, and they supply a room and a refrigerator or whatever for their employees, so that if they go out on maternity leave and they want to return and breastfeed, that's all there for them. So they can just come and use that at their company. Some of the other things we're doing is collaborating with Planned Parenthood. We have set up a program where when our community health workers meet women in the community and they meet a woman who's not on birth control and would like to be on birth control, the CHW sits and goes over all the birth control. We purchase birth control kits from Planned Parenthood. So they go over that with the client, and when she decides what she wants, we are able to call directly to Planned Parenthood and get that girl in to see them the same day. So rather than putting it off and making an appointment that they might not get to, we can get them there that day and get them on some kind of birth control. So that was, we were really excited about that, because that is definitely one of the issues that we saw, that, you know, clients never got there. So, so that's a really positive thing for us in our county. We also share data with the hospitals, you know, trying to figure out women who are coming to the hospital to deliver babies who are addicted to drugs. That's something that doesn't show a lot in state data, but we meet with them and we talk about those issues and see how, you know, how prevalent of a problem that is here in Orange County, and how we can, you know, attack it. Let's see. I just had a list of things here. We also do, we also have a good relationship with the Friends House, which is the teen shelter in Orange County. So that's really just a short-term, teens can come in there, you know, just for a night, or they could be there for a couple months, depending on what their situation is, why they came into the shelter. But we have set up an agreement with them where they refer those girls as they come into the shelter, and our community health worker goes up and sits with them and does the reproductive life plan with them. So she talks about, you know, all the different aspects of a life plan and where their life is going and moving forward. We help them out with whatever we can. In the shelter, they are case managed. So I know in the adult shelter, you know, they're doing all that work with these clients. So it really, you know, we try to do the life plan and help them out with whatever the shelter is not helping them out with. I don't know, did you want me to talk about some of the struggles that we have?
Yeah, any challenges in trying to get people?
Okay, probably the biggest challenge we have is with the health centers, because they seem to, you know, they're federally funded health centers, and they seem to want to be a one-stop shop for their clients. So they want to be able to do everything for them in-house. So it's like they don't need our services because they got it all covered. So trying to, you know, talk with them and to see how we can fit into that puzzle has definitely been a challenge. We do have some collaboration, you know, as far as doing programming. We go in and we do some programming for women. They don't mind us doing that. But, you know, I think definitely one of the lessons we've learned about it is like you had said, getting to that right person. That person that really buys into the program and sees the importance of it and can pass that along as far as making referrals and, you know, staying connected with us. If you can't find that one person, it's definitely hard. I've met with many people, you know, at the hospitals or, you know, the health centers and haven't really gotten very far. You know, we met with one of our hospitals. I met with several of the, you know, management people and didn't really get very far. And then I had a meeting with the Nurses Association from the OBGYN floor, and now they refer to us. You know, so it's just finding that one person in the right place to get those referrals and, you know, get connected to those women that are at risk that we really need to be connected to.
Right.
So, you know, I think we're definitely doing a lot. We're working a lot with our partners. We're trying to get those MOUs to get on, you know, their policy, including us in their, you know, their work that they do. I know with the adult shelter, I'm working on getting an MOU where they can refer women as they leave the shelter. So now they're leaving the shelter, they're leaving that case management, and they're on their own. So I'm trying to get them to refer these women on discharge, so then we can meet them in their home and we can do a life plan with them, and we can, see how they're doing and what else, other services they need to be connected to. So that's, one of the big ones that we're really trying to work hard to make that connection with them. As far as our survey goes, like I said, we did look it over. We certainly want to work on, there are some, places and agencies that we don't have that great connection with that I feel like we really should. So that's definitely going to be one of our focuses on getting better connected to those services and bringing them into our, our advisory board. We actually talked about having, making it a collaborative instead of an advisory board so that maybe some more work can be done and some more partners can be brought to the table.
Right. That
sounds that's about covered.
Sounds great. So it sounds like you're at the collaboration stage and you're trying to formalize some of the partnerships. And of course, there are always challenges when it comes to relationships and building relationships with agencies and getting buy-in. So, but thank you for sharing. Sounds like you're doing a lot.
Thank you.
Did anyone have questions for Mandy? Any questions or comments? Okay. Well, thank you, Mandy.
All right.
We're gonna move on. Of course, if you have questions at any time, you can raise your hands. Raise your virtual hand, and Pam will get to it. So we're going to come back to this, and if you don't mind thinking about how you would respond to some of these questions regarding what elements, where do you see yourself, and what elements you think that you would plan on improving, and specific next steps that you would want, and any challenges. And lessons learned are also important, because if you figure out how to engage one type of agency, we would be all ears to hear about recommendations and lessons learned. So we'll talk about keys to effective collaboratives, and then we'll come back to the discussion. So there are many models and formulas and all kinds of things out there, but based on what I've seen, I really like Eduardo Salas's 8 C's that he suggests and he talks about. Again, there are many others that might be just as good or better, but he talks about conditions, cooperation, coordination, communication, cognition, coaching, conflict, and clarity. So we'll go through each one. And if I were to ask you which one you think is most important here, I would be curious to see what you would select as the most important key to effective collaboration. Anybody want to guess? So many say communication. I think communication has been the most common belief that it's important, right? Yeah. So every time I talked about this, it's always communication that comes up. It's important. But he argues that actually conditions are the most important. Because it doesn't matter how much you communicate, it doesn't matter how much you buy in, it doesn't matter how much you try to coordinate. If the conditions are not right for you to have a collaborative, it's not going to work. So you have to have the appropriate condition in order to have a collaborative. So by conditions, he's talking about policies, incentives. Incentives are not necessarily money or actual tangible things, but incentives could be a buy-in, really, if we join this collaborative, what's in it for me? We are selfish beings. we do everything for a reason, whether it's altruism or an actual benefit. So there has to be some incentive for people to join a collaborative. If you're just meeting and talking, they probably won't come back. There also has to be what we always talk about in collective impact, which is the backbone agency. You have to have some form of initiating agency that provides the conditions and encourages people to meet and to work together. And hopefully they give the resources too. So in our case, we definitely have the conditions. We have the right conditions for you to create collaboratives. We have the National Call for Collective Work. We have the Department of Health that's supporting and actually expecting the programs to work collaboratively. And I believe that there are actually resources also available for that. And then you have us. We're here to help you in any way we can to build collaboratives. And then you have the programs. Within the programs, the maternal infant health programs, image programs, you have the incentive for actually working together. So this is a quote from Dr. Salas. You can have the best team in the world, but if the conditions are not optimal for teamwork, you won't get the behavior, cognition, or attitudes you need to be successful in your collaborative. So, so conditions are extremely important, and we do have the right conditions to improve collaborative work. I'm sure we would like more funding and perhaps more of other things, but we definitely have the basis. The second one is cooperation. So you have to have agencies that are willing to be on a team, that want to be there, that trust each other, that want to contribute to whatever objective you're working on together. And so if we look at our maternal infant health programs, we have very good levels of trust based on the survey. I think it was over 70% for everyone. There's a general willingness to be on the maternal infant health partnership, but many of the partners surveyed talked about needing more clarity about their role. So if I'm on this maternal infant health and I'm part of the housing department, what is how can I contribute to maternal infant health, and what is my role and potential contribution? So here, when members fail to contribute, they call it the social loafing syndrome. So basically, they're just sort of there, but they're not contributing anything. So you want to make sure that your partners are contributing. The next one is coordination. Here you want to coordinate. In coordination, you want mutual support, flexibility. You want to coordinate processes. So whatever your task is, whatever your objective is, you want the processes to match, and you want to make sure that you're working towards that. You're verbalizing the plans, you're sharing the information, you're supporting each other and getting to that goal. So we do have some levels of mutual support in the programs, the partners that we looked at from the survey. But obviously the programs that didn't know what their role was, they weren't able to contribute as much. So there's room for improvement there. It goes back to the clarity that we'll talk about in a second. Flexibility, again, it varies by agency, but when you're working with others, obviously, there needs to be a certain amount of flexibility when coordinating meetings, communication methods, etc. So identifying what works best for everyone and working on that. So communication, which we all know communication is important for any relationship, and definitely for collaboratives. And it has to be precise, it has to be timely, it has to be clear. And as you're building collaboratives, as we mentioned earlier, you really need to have in place methods for exchanging information. And with the age of webinars, online webinars, phone conference calls, etc., what's been found in the literature is that really you have to have face-to-face meetings. Otherwise, it kind of kills the collaborative. So obviously, conference calls are okay, webinars are okay, but you want to make sure that you have face-to-face meetings with your partner. Otherwise, it really hinders communication and engagement from the partners. So we do have a lot of informal communication among the MITCH programs, the McGree programs, the COE, etc. And within your partnerships, again, there are different degrees of, varying degrees of protocols, the formality for exchanging information. So some individuals have regular meetings, others don't have a regular meeting, and they're relying more on informal communication or emails, etc., phone calls, etc. So the key is to make sure that there's something in place for exchanging information. It makes it a lot easier, and it makes it, it keeps the engagement of the partners. As far as cognition, really it's having that shared understanding of tasks and role and knowledge of the resources that you have within your partnership. So again, if you think back to your partner survey report, you'll see that the amount of shared understanding among your partners. So do they really understand their role? Do they really understand their potential contribution to maternal infant health? So ensuring this is important. As far as coaching, it's really promoting teamwork, leadership, building trust, making sure that everyone understands the norms of the collaborative, that you have team building exercises, that you focus on the conditions that will promote success. And as far as our programs, we have state level leadership. Obviously, that's the overarching backbone agency. They organize statewide meetings, trainings in person as well as not in person, etc. And through their leadership and expectations, we know where we need to go. At the program level, again, there are different levels of leadership for each local collaborative. So the key is to think about yours and what you would need to do to improve that. Conflict. Anytime you have a relationship, you have potential conflict. But again, the higher the trust level, the more listening happen, the more you have common ground, the less you will have problems, the less conflict you will have within the collaborative. And one thing that Dr. Salas really pushed on was focusing on problems, not people. So if there's an issue, it's the issue that's the problem. It's not the person bringing it up or the person involved. And he said that helps kind of playing the blame game. Instead of playing the blame game, we're focusing on the problem, and let's work together to solve it. So for us, we have the forum for reporting needs and listening to program needs and issues through the meetings, the monthly meetings that the leadership has with the DOH. You have the opportunity to provide feedback through evaluation activities, etc. So at your program level partnership, again, it's identifying how much leadership there is and how much you need to work on it or how well you're doing to to set a stage where you won't have as much conflict, as well as figuring out how to deal with conflicts if they do happen. So, and I'm describing the overall maternal infant health because I see us all as a partnership, a statewide partnership to improve maternal infant health, led by the Department of Health. So it's kind of the overarching partnership, and then within the partnership or collaborative, you have the program level partnerships. So at the statewide level, I'm sure that there are areas to improve as well, and that's where you come in as far as providing feedback on evaluations or during meetings, etc. So the clarity, again, extremely important. It's one of the biggest hindrance to collaborative work. If people don't understand the mission, if they don't understand their role, their responsibility, then they're not going to do what's needed, obviously. And it also discourages them and reduces their engagement in the process. Because if you go back to the incentives, if they're not incentivized to participate, and if they don't see the end objective, they're not going to be engaged. So for our state level partnership, we have the DOH that provides directives, and some are clear, and if they're not clear, then we have opportunities to ask for clarification. And then we have trainings and information from us at the COE to facilitate some of these directives and expectations. And at your program level, obviously, again, various degrees, but the key is to make sure that based on your report and some of the comments from your partners, that you address the issue of clarity. So your next step could be at the next meeting, we're going to talk about the overall objective of the partnership and maybe discuss the role that everybody might play in providing assistance for the community. So those are the 8 C's. And as you're planning, there are many ways to do planning, but these are, you could take these 8 C's and figure out where you are. And there's actually, and we're going to send you the exercise sheet for this if you would like after the webinar. But this is something that can really bring up the conversation in your meeting with your partners. So if the next collaborative, whether you have a CAN or a collaborative or an advisory board, whatever your partnership is called, you could easily do this with your partners. So talking about condition, cooperation, coordination, etc. I think clarity is at the bottom. It got chopped off, but yeah, clarity is at the bottom, but you don't have it on your. So have discussed this on a scale of 1 through 4. How well are we doing with these statements? Are we doing well? Do we need to improve? If everyone rates it a 1, then you know that you have an issue with this area. So if it's communication that gets a bunch of 1s and 2s, then okay, what are we not doing right? How can we improve communication? Do we need a listserv? Do we need somebody to be in charge of communication? Et cetera, et cetera. So this has been shown to really help partnerships or collaboratives talk about specific action items that they need to do to improve their collaborative. So it's a very quick assessment of where we are and then what we need to do for each C. So again, I'll send you the exercise. But this is the questions that you might ask afterwards. So which C was our strongest? Which varied the most, meaning inconsistent ratings across members. So that means some people are satisfied with it, think that we're doing well, and others don't think so. So where is the disconnect here? Which C needs improvement? What can we do right away to start improving some of our lowest rated C? So again, very good exercise to start the conversation with your collaborative and go directly into planning and immediate, very specific action steps. So we will send you that. Rachel, are you on? I think Rachel is on. So, so these are the basics of one way of looking at successful collaboratives. So Rachel is here from Public Health Solutions, so I'll let her talk about her experience with their collaborative.
Hi, everyone. So Amina had asked me to just talk briefly about a couple of questions. One was kind of where our partnership currently is, if we have a formal group, or what that looks like. And we actually are going through a big transition right now. We really started up our collaborative just a few months after starting the program in 2014. And I think did some really transformative work in the first 2 years. We did a lot around kind of the social determinants of health. We had a pretty active work group structure that was meeting twice a month for a while, and very active participation. Over the past year and a half, I would say, that has waned a little bit. And then other organizations also in our community have started up community coalitions. So when we started here in Northwest Queens, there really weren't that many community coalitions other than the Partnership for a Healthier Queens, which is really nutrition and physical activity focused. And so over the past year and a half, we've kind of taken a step back, I think, on some of these general community issues that definitely have an upstream impact on maternal child health. But we're really trying to zoom in now, more specifically around maternal child health issues. So I think we've had a little bit of mission fit and mission shift, which is something we try to be aware of. And even if it's happening, just kind of communicate with people about that. We're really shifting our focus a little bit. Right now, what our collaborative looks like is we're not doing as much as a large group, although we are doing a little bit, and we're really focusing in on 2 new projects that we have. So that's taking away some of the attention from the larger collaborative, but it's really true to what we're here to be doing, which is providing maternal child health support to women most in need. At the same time, I guess we're trying to be responsive to what our partners' inputs and needs are. And so I know something that's come up for a lot of your programs, and we also had our partners reach out to us as a resource regarding the current political climate and the concerns, since we work in a community that has a lot of undocumented folks. So we're kind of, as an example, our May meeting, which generally would be a general collaborative meeting, we're hosting an all-day immigrant navigator training. So it's not really a know your rights training. We've hosted several of those for community members. This is really a resource for our partners to learn to be advocates and how to address some of the non-legal components of what's going on and how to be a support for them. So that is, we're trying to still be responsive to some of the larger community issues while we are focusing in more on MCH issues. I guess another question was any lessons learned regarding partnership building. I think, obviously it takes a lot of maintenance and love. I kind of think of partnerships now the way that we often talk about policy in terms of big P policy and little p. So we have our big P partnership, like I said, in terms of the collaborative, but we're really focusing in now on the little p and strengthening some of those direct relationships within the larger collaborative. And an example that comes to mind for that, we used to do family planning and reproductive life planning for the local high school. When it came out last year that we're not supposed to be doing that, we forged a partnership with CAP here in our county, who we tried to partner with before. It hadn't happened. So I kind of doubled down on those efforts, and now they're taking over our family planning education at the large local high school. And it's been one of the, growing pains that our larger collaborative would have from meetings. And we tried to always, people like to hear updates, what's going on in the community, but we tried to shift away from that, since a lot of other meetings kind of look like that. You have a presentation and you hear updates and that's it, and nothing really ever changes. So we try to stay away from that. But one of the challenges, I think, in CAP is a good example is they do specific adolescent pregnancy prevention education. That is the one key thing that they do. So even them coming to our larger Mitch meetings, when it seemingly has very much to do with maternal child health, they were kind of out of the purview of of specific perinatal health issues. And so that was kind of something that I was just mindful of. And so they don't necessarily, to be an active partner, need to come to those larger collaborative meetings, but we can stay linked in with them and have a very close partnership, even if they're not part of that kind of larger structure. Yeah, anything else, Amina?
Yeah, I was just curious about the, first of all, it sounds like you're doing a lot. Yes, the partner tool survey, the partner survey, just curious how you used it, or if it helped you identify areas that your partnership would need improvement, if you made any decision based on it, etc.
So yeah, the partner survey was fine. I think in essence, it told us somewhat of what we already knew. We did present it at our December meeting. We didn't go over all of, how people rated each other, but we did present some of the more qualitative feedback that we got out of it, which was really interesting. I think in terms of kind of the visual spider webs, what was interesting to see, and it kind of makes me question what our role is again, is that, everybody was pretty clearly connected to us, but then how they're connected to each other is not always clear, or was not as strong.
Right.
And so to some extent, while I think it's our role to kind of help strengthen that network, is also on the day-to-day thing of managing a community health worker program and all these other things, like that might not be feasible for us to go always strengthen relationships between, X and Y sites that provide additional services in our community. But at the same time, it's brought up an interesting, I guess, predicament in a way, is, in terms of us tracking referrals, to me, a better, stronger system is where like each organization would know about each other and directly send them as referrals. I don't necessarily want, I'm making this up, but one client from WIC to come come through us to then go to a mental health clinic, if that connection could be made directly. But at the same time, if we're, doing a numbers thing and playing the numbers game and trying to track that, what does that look like? And I don't know that any of us at this point have systems where referrals can be going through the community that we can track and aren't necessarily flowing through our office. And so that's been something, I don't know if that's like, collaboration 2.0, but that we've been percolating on a little bit, is like, what does the real referral network look like where we don't have to have them all flowing through us, because we also have limited capacity. So the partner survey, to some extent, I guess, kind of helps me to visualize that is what is happening, and to have a little bit of conversation around what we can do to strengthen the whole network and not just have everyone have such a strong relationship to us as the centerpiece.
Mm-hmm. Yeah, thanks for sharing. And as far as a system of managing referrals, that's like the high level collaboration. So that would be the ideal, of course, but definitely something to work towards. So, yeah. Does anyone have any comments or questions? Does anybody want to share some tips or lessons learned regarding building partnerships? I don't want to put them on this. Okay, I don't see any hands raised. No comments. Okay. So I hope at least I gave you one more tool to use, perhaps to have an exercise with your partners or your collaborative members. So again, the next steps, really share the partner survey results with your partners if you haven't already. And feel free to contact us if you're not sure what to share or want suggestions on how to share it. So I can tell you that most of the programs that I've spoken to have shared it at a meeting and provided the results. The general results without, of course, the individual ratings, which should not be shared. Just the overall ratings and the comments and the resources. reaching out to key partners. So who is missing, what sectors are really weak. If you think about social determinants of health, what areas do we not have really strong partnerships that we need to reach out to partners? And also, how are we doing with the partnership with our local McVie? If you're a McVie program, reaching out to your key partners, and also making sure that you're working with the local Mitch program as well. So it's a two-way street here. If you haven't been engaged, then you want to make sure that you do become. All right. So I see a comment from someone about to build partnerships takes a strong understanding of the resources your partners bring to the table. Absolutely. And it was interesting to me for me to look at the resource section of the partner tool survey. If you look at the results, there's a huge table with the resources that the partner said that they could provide. So again, that's another conversation starter, and also being aware of what your partners can contribute. So resource sharing is important, absolutely. Other key partnership areas. So again, you know best what programs you need to have at the table, but these are some suggestions, making sure that you are in partnership with the local CAP, family planning clinics, the regional perinatal centers, and of course your McVie funded programs, and any other home visiting programs that are in your community. Because these are all maternal infant health programs, but you need to have a strong basis and make sure that you're all working together, because you're all serving the same population, as well as inviting people that are outside of maternal infant health. So these are just recommendations for key partnerships that we would hope that all of you are already partnering with or are working towards. So you all have been very quiet today, but any comments, questions, again, just feel free to type it up. There are a few opportunities coming up for networking across the state. So I was going to let Raquel talk about that.
So this is, I'm sure you've received some of the emails as reminders or save the dates. So here's one opportunity that in conversation with our DOH team, we are basically dedicating one of our 2 days of our annual meeting to be a joint day with our other two bureau COEs, the family planning and the adolescent act for youth COE. So we will dedicate our May 10th meeting to be in the same room with all of these providers that are also providers in the same communities that you are located. And this is an opportunity to see where the overlap is, get to know each other, where are the opportunities for partnering and engagement and referring to each other as well. So this is a state meeting where there's an opportunity here. Our day one is dedicated to meeting with each other. So we will be sending this information out in a day or two. But the location will be at the Desmond Hotel, just as we had last year. So you should be familiar with your with this location. Just FYI, May 9th, you can bring up to 4 people as we did last year. However, the May 10th, because we're bringing all COEs together and providers and other partners, that has to be limited to 2 staff per program. And ideally, the staff that we want here at the May 10th are the managers or directors of the program where they can make decisions on behalf of the program about how to partner and make this with across the providers. That is an opportunity here at the annual meeting. Feel free to contact either myself or Pam for any details, but the registration will be sent out soon. We appreciate your participation today. If you have additional comments, please send us an email, unless you can feel free to chat, put comments in the chat right now that we can address at this time.
Any questions, comments before we end? While you're thinking, I want to apologize for my voice. I have a cold again. Seems like every time I do a webinar, I have a cold. So thank you for putting up with my very nasal voice. So I don't see any comments. So we will be following up with the little exercise with the C's. If you're interested in putting that in your toolbox. There are upcoming trainings, and so thanks for listening, and I will let Pam close up by telling you about the upcoming trainings.
I did see one question also on the group chat, which was who will be involved on the May 11th meeting date. That day is actually just the annual meeting for the family planning COE only. We're doing our annual meeting on May 9th. And then the Joy Day on May 10th, and then May 11th is just the family planning COE. So none of you guys will be expected to stay for that unless you are somehow involved with them as well. And then they may invite you directly. We have a couple of trainings coming up. The next one's coming up in April. We have the Power of Presence training in New York City on April 6th and 7th. And then we have the client engagement training for CHWs in Buffalo on April 6th and in Syracuse on April 13th. And then our next webinar is Cultural Humility, and that is on April 25th. All of the details and the registration links are available on our website, www.mihcoe.org, as well as all of the other trainings that are scheduled between now and the end of June. There are about 4 or 5 more webinars coming up between now and the end of June, as well as just a couple of in-person trainings there. I did see another comment. It says, the coordinated intake projects give those programs a great opportunity to increase partnerships and level of collaboration locally. It's a good comment, thank you. All right, I think that's everything, unless anybody else has something that they would like to, anybody has any questions or has anything they would like to discuss. All right, well, thank you everybody for attending. Have a good afternoon, and we'll send out the additional information to you either later this afternoon or tomorrow. Thank you.